Hello and welcome to today's program, Mechanisms to Medicine, Tackling Eosinophilic Disorders. A focus on eosinophilic granulomatosis with polyangiitis and hypereosinophilic syndrome. We're excited to have participants joining us from across the country, both here in person and online. This program is provided by Integritas Communications and supported by an independent educational grant from AstraZeneca. For our live audience, you'll find a few important items at your place setting: a booklet with program slides and accreditation and disclosure information, a postcard with a QR code that gives you digital access to slides, program information, and additional resources, a two-sided evaluation form. Please complete it and hand it to an usher at the end of the program, a keypad to respond to polling questions. Your responses are anonymous and very important to the educational outcomes of this program. For those joining us online, all this information is available under the Handouts tab on the right side of your screen. The evaluation will automatically open in your browser at the end of the program. Please do not exit out of the screen. To ask a question during the presentation, please write it on the questions card in front of you. Ushers will be around to collect them. Online participants can use the Q&A box on the right side of the screen. Now, let's give a warm welcome to our presenters: Dr. Anisha B, Dr. Flavia Hoyt, and Dr. Michael Wexler. Thank you and enjoy the program.
Thank you all of you for joining us this morning. I know it's early. So today we will be tackling eosinophilic disorders with a focus on EGPA and HES. So let's go ahead and get started. Here are our disclosures and our educational objectives. So we will start with pathophysiology and also talk about the biopsychosocial burdens. We'll identify patients, and these two disorders have a lot of similarities, so trying to kind of differentiate them. Analyzing some clinical rationale and trial evidence for biologic therapies, and then talking about individualizing therapy, optimizing disease control, and aiming for that long-term disease remission. So let's start with some pre-test questions. You each will have a little remote thing. So we'll give a few seconds for each of them, and then we'll jump into the content. So first, approximately how many patients with EGPA do you manage each year? None, 1, 2 to 4, 5 to 10, greater than 10, or I do not manage patients. And our next question is similar. So now we're talking about HES. So how many patients, same options for HES. And pre-test question 3. So which of the following is a therapeutic target for both EGPA and HES? Janus kinases, interleukin 5, IL-5R, tyrosine kinases, or interferon alpha? So pre-test question 4, which of the following eosinophil levels correspond to diagnostic criteria for HES and EGPA? Read carefully. So HES of greater than 1,000, greater than 500, or greater than 1,500. And then the EGPA criteria greater than 1,500, 1,000, 2,000, or 1,000. And look closely at those combinations there. And now a clinical vignette. So a 65-year-old woman diagnosed with HES after presenting with weakness, night sweats, vomiting, and an eosinophil count of 3,600. She's tested negative for FIP1L1 PDGFRA fusion, and her secondary causes of eosinophilia have been ruled out. Corticosteroid therapy is initiated, and now she's stable. So which of the following is the most appropriate next step for her? 1, continue the steroid therapy and monitor her eosinophil levels. 2, initiate treatment with interferon alpha and wean her corticosteroids. 3, initiate an IL-5 targeting biologic and wean her corticosteroids. And 4, initiate treatment with hydroxyurea and wean corticosteroids. Okay, another clinical vignette. Here we have a 59-year-old man, history of severe asthma, diagnosed with ANCA-positive EGPA 3 years ago. He's well managed on azathioprine and prednisone 10 milligrams per day, though he cannot taper any lower than that. He's starting to have some corticosteroid adverse events, and so which of the following would be the most appropriate next step for him? 1, increase the azathioprine in order to taper the prednisone. 2, just discontinue the prednisone. 3, switch azathioprine to an IL-5 5R targeting biologic and then taper the prednisone. Or 4, switch azathioprine to methotrexate and discontinue prednisone. Okay. I think this might be the last one. So pretest question 7. Approximately how often do you currently use a biologic therapy to help taper steroids in a patient with EGPA? So never, 25%, all the way up to 100, and then I do not manage patients with EGPA. Sorry, I lied. But that means more music, so keep waking us up a little bit here. Same question, except now we're talking about testing for FIP1L1 PDGFRA in patients with HES. So how often does that happen currently? So let's move on. We're going to start with burdens and pathophysiology of eosinophilic disorders. So let's start obviously by talking about the eosinophil as a cell. And we know that it's a multimodal cell, so it's not just kind of a biomarker that we follow in clinic. We know it has roles in health as well as disease. And so in terms of health, we know that it maintains homeostasis. It's involved in tissue repair and remodeling. It plays a role in immunoregulatory and protective roles, particularly obviously with Helminth infections. But then if you have too many eosinophils, or if they're not the right kind of eosinophil, you can have pro-inflammatory role, and it looks mostly like type 2 inflammation. And then if there's enough of it, you're going to have tissue, organ damage, and poor outcomes. Across multiple disease states, the higher the eosinophils, the worse the outcome. And so we know systemic inflammatory diseases associated with eosinophils. The two big ones, the ones we're going to be talking about today, are EGPA and HES. And in these patients, there is an unmet need of delayed diagnosis. So really having a high index of suspicion is important. And then, of course, corticosteroid burden and all the side effects that come with corticosteroids. So first, an overview of EGPA. This is a rare autoimmune condition. The inflammation is in small and occasionally medium-sized blood vessels throughout the body. The incidence is approximately 4 cases per million, so again, rare. And it is adult onset, so median age of onset is 4th or 5th decade of life. And it's characterized by these necrotizing granulomatous vasculitis. It is an ANCA-associated vasculitis, and it is distinguished from GPA and MPA, the other two ANCA-associated vasculitides, based on this triad of asthma, nasal polyposis, and peripheral eosinophilia. So once you see those in an ANCA-positive patient, definitely think EGPA. Greater than 90% of patients with EGPA have a prior history of asthma. And this is sort of the classic teaching about the stages of disease progression, but we all know in clinic that you see the arrows kind of going in all directions. So it doesn't always follow the disease progression shown here. However, we think about the prodromal allergic phase, so asthma, chronic rhinosinusitis, and then some systemic symptoms, fever, weight loss, malaise, myalgia, arthralgia. Then the eosinophilic phase, here's where the peripheral eosinophils really shoot up, and you start developing organ involvement, so lungs, GI tract, and cardiac. And then once you move into the vasculitic phase, the organs that get involved are more the peripheral nerves, kidneys, and skin, and again, the vasculitis is of the small and medium vessels. In terms of the EGPA burden, so it's not just bad asthma. Really, these patients have a very significant impact on their ability to work, exercise, sleep, and of course an impact on social activities. And we know, like I mentioned before, there's a diagnostic delay, there's misdiagnosis in more than a third of patients, probably even higher than that. And patients notice that there's a lack of, because of this lack of diagnosis, there's increased burden from steroids, as we mentioned, but there's also a lot of high cost in kind of getting to their diagnosis and then treating. And once you have organ damage, obviously there's more costs associated with that. So moving on to HES. HES is not just one single diagnosis, it is a heterogeneous group of rare conditions characterized by hypereosinophilia, eosinophil-mediated organ dysfunction and or damage. So that's important. You can't just have high eosinophils. There has to be involvement of the tissue and the organs. And also important, no other identifiable cause of eosinophil-mediated organ damage. So we'll talk about what some of those causes might be. And again, there's a wide range of clinical features to HES, and that makes diagnosis more difficult, typically associated with cutaneous, pulmonary, neurologic, and gastrointestinal involvement, but you'll see it can involve the whole body. And the incidence and prevalence is not well characterized, even more rare than EGPA, probably based on database estimates, about 0.4 cases per million. With HES, it's very important to identify subtype, mostly because it will very much guide your therapy. So myeloproliferative HES, which we'll call MHES, is due to underlying stem cell myeloid or eosinophil neoplasm. So it's really a neoplastic condition. The eosinophils are clonal, and the end organ damage is a result of this hypereosinophilia. The most common mutation seen is the PDGFRA gene that's mutated, often with FIP1L1, but there are some other varieties as well. Lymphocytic HES is thought to be cytokine-driven, and so here you have a T cell clone that is aberrant and is producing a lot of IL-3, IL-5, GM-CSF, and that leads to eosinophilia, which then causes organ damage. Idiopathic HES is again, clinically can look like the other two, but you're not able to identify the myeloproliferative or lymphocytic abnormalities on testing. And again, hypereosinophilia is what leads to the organ damage. And then familial HES is very rare, and it shows familial clustering. And there's, again, no evidence of that reactive or neoplastic condition. Patient burden, again, very dramatic. So delays can be up to 20 years in terms of diagnosis and finding effective treatment. Patients will talk about how many clinicians they see before they finally get a diagnosis. So 70% are seeing more than 3 clinicians. 83% are agreeing that HES symptoms are burdensome to their family and friends. And you can see on the right there is a word cloud from patients talking about how real this disease is, the symptoms, the pain, lack of treatment, how long-term it is, and you can see all the different words that kind of pop up about frustrations and impact. And the most common effects on quality of life are, again, ability to exercise, work, and participate in social activities, and of course, anxiety and worry.
Eosinophilic granulomatosis with polyangiitis, or EGPA, and hypereosinophilic syndrome, or HES, are both rare eosinophilic disorders that result in damage or dysfunction in multiple organ systems. In both EGPA and HES, activated eosinophils have pro-inflammatory effects that lead to tissue damage that is mediated through the release of cytotoxic granule proteins in their cytoplasm and secondary involvement of other immune cells. In particular, eosinophil survival and mobilization from bone marrow are mediated by IL-5. Interestingly, once eosinophils leave the blood vessels and migrate into tissues, they do not recirculate, and their survival in the tissue depends on local production of supportive cytokines, such as IL-5, that prevent apoptosis for several days. Activated eosinophils can also produce a prothrombotic microenvironment through the endothelium and other pathways, increasing the risks of arterial and venous thrombosis. Depending on the presence of anti-neutrophil cytoplasmic antibodies, or ANCA, EGPA may have more vasculitic or more hypereosinophilic features. ANCA-positive disease is more associated with vasculitis that is mediated by both neutrophilic and eosinophilic infiltration, whereas ANCA-negative disease is thought to be mediated primarily by eosinophil tissue infiltration and eosinophil-mediated organ involvement. Improving patient outcomes in these disorders is of utmost importance. Some therapies that target either IL-5 or its receptor are FDA approved, or in late-stage development, for EGPA and HES.
Sorry about the lack of introduction to that wonderful video. I hit the button a little too fast. But so you just saw about kind of the role of the eosinophil and what happens in EGPA and HES. And so you can see here for EGPA some of the players that we just saw in the video. Certainly you think about the eosinophils, entering the blood vessel, leaving the blood vessel, and then going into the tissue, and the release of their mediators such as EDN, ECP, and MBP are these toxic granule components that enter the tissue and cause damage. But you can also see kind of the complexity of EGPA. It's not just about the eosinophils. It also has to do with the B cell forming antibodies that then cause deposition, like the ANCA we just mentioned, in the blood vessels, so vasculitis. There's a role for Th17 and Th1 immunity that leads more to the granulomas. That's part of this granulomatous vasculitis, and ultimately all of that leads to the tissue damage. In terms of HES, so I alluded to this earlier, the dysregulation is in the cytokines. So the pathophysiology is not completely understood, but there is not that vasculitic component. It's more about dysregulation of IL-3, IL-5, and GM-CSF. And thinking about the neoplastic versus the lymphocytic can kind of help understand what's going on so you can better target the underlying pathology. And so in the neoplastic HES or MHES, you see the clonal eosinophilia caused by these genetic abnormalities, again, FIP1L1, PDGFRI being the most common, and treatment is really going to be targeted, generally starting with imatinib, which works very well in these patients. If you rule out the FIP1L1 PDGFRA and you're looking more at the lymphocytic HES, now we're talking about these clonal T cells, and they're producing a ton of these cytokines, the IL-3, IL-5, and GM-CSF, and you're left with a lot of eosinophilic inflammation. And the cell surface markers that kind of distinguish these T cell clones, the most common is going to be CD3 minus, CD4 plus, but then you can see there are other varieties as well. And there is some potential for malignancy in the LHES, mostly lymphoma. And so thinking about therapies for both EGPA and HES, again, thinking about the pathophysiology can help direct that therapy. So you can see on the left of the slide, we have some of the cytokines that were just mentioned, so IL-4, IL-5, IL-13. And the therapies that are approved are going to be mepolizumab and benralizumab, which are targeting that IL-5 pathway, either by targeting IL-5 directly in the case of mepolizumab, or IL-5 receptor alpha in the case of benralizumab. But there are some other therapies that are being looked at, so dupilumab blocking IL-4 and IL-13, dexpramipexole, which kind of halts the progression of maturation in the bone marrow of the eosinophil, lirentelimab, which blocks the Siglec-8 inhibitory receptor, which is on the eosinophil, but also on mast cells and basophils. And then if you're thinking more in terms of EGPA, the antibody formation vasculitis, you're going to be thinking about blocking the B cell through CD20 with rituximab. And really just kind of looking at the complexity here, thinking about what part of that complexity is driving your patient's symptoms, then can help you target specific to that patient. So question for my colleagues here, and for all of you to think about, So how can clinicians use this shared pathophysiology that we saw in the video and that we also talked about in the slides to kind of help guide clinical practice?
Yeah, I think it's really, really important to think about the pathophysiology of what's going on in a given patient. So, maybe go back to the last slide so we can talk about all the different options that we have. I try to identify and see a specific phenotype and or a specific endotype for those patients to try to figure out what mechanism does the patient have and what type of hypereosinophilic syndrome does the patient have. And if they have a predominance of eosinophils, I'm going to target IL-5 or the IL-5 receptor with the goal of depleting the eosinophils by blocking IL-5 activity. In some patients, who have more of a B-cell mediated disease, so the pathophysiology depicted on the right-hand side of the slide, those people I'm going to want to target their B cells to prevent antibody formation. If they're ANCA positive, if they've got other antibodies, those are the kinds of things I'm going to target. Now you need to look broadly, and are there other factors going on? Does the patient have not just eosinophils, but do they have broader type 2 inflammation going on? So if they have beyond just eosinophils, if they happen to have really high nitric oxide, you may not necessarily have complete beneficial effects by just blocking IL-5. And sometimes in a off-label way, I might consider giving broader drugs either in combination with or instead of the anti-IL-5s. So I've given tezepelumab, which is currently being studied. It's a TSLP blocker that works upstream and blocks IL-4, 5, and 13. But again, that's being studied in a phase 2 trial. And sometimes I've given dupilumab as an add-on on top of the anti-IL-5 therapies. So it really depends on what's going on. Currently, we only have 2 therapies that are approved for EGPA and HES, and those are mepolizumab and benralizumab. But I'm excited, and we'll talk a little bit more later on about other therapies that are in development. Anisha?
Agree. No, I do think that you have to look at obviously the patient in front of you. I think IL-5, in terms of shared pathophysiology, you block that. But even with the ANCA-positive patients where I'm thinking about rituximab or Cytoxan in severe disease, I will often use IL-5 blockade or something like that as well. And I also do the combination stuff where if someone has a pretty good response in terms of their asthma with an IL-5 blockage, but they still have sort of some persistent rhinosinusitis or major nasal polyps, I'll sometimes add dupilumab on top of that as well, again in a non-official way, just to see what I can do to control the patient's symptoms.
Yeah, no, that's great. And I feel like you can get a sense for the multidisciplinary approach up here. So that's very important, and we'll talk a little bit more about that as well. So let me pass this over to Dr. Wexler here.
Thank you, Flavia. So really exciting. Thank you guys for coming this morning. It's good to see all of you at this bright and early hour. We're going to talk a little bit about some of the diagnostic challenges in HES and EGPA. They're not quite so straightforward. So it's important to have a broad approach to recognize what could be going on in a given patient and how do you come to a specific diagnosis of HES and EGPA. And sometimes it's like finding a needle in the middle of the haystack. And you have to really take a lot of clues and really do, find all the pieces of the puzzle and put the pieces of the puzzle together in order to come to a diagnosis. Because these aren't straightforward diseases. They can be challenging to manage. They can be challenging to make a diagnosis. And as Flavia said, it can take years in some patients to come to a diagnosis. So there's this broad differential of eosinophilia. We talked already about hypereosinophilic syndrome and EGPA. But in order to make a diagnosis of either of these entities, you have to exclude other causes of eosinophilia. And there are the primary eosinophilic disorders, like HES, and then there are ones that are derived in the bone marrow, eosinophilic leukemia, myelodysplastic syndrome. There's familial diseases that, like a familial HES, similar to hyper IgE, where you have, or Job syndrome, where you can have markedly elevated IgE levels in the thousands. Oftentimes, you can also see that associated with eosinophils. And then just benign hypereosinophilia as well. Then there are secondary causes of eosinophilia. So whenever you see high eosinophils, you should be thinking broadly. And does the person have a malignancy? Do they have a solid tumor? Do they have leukemia? Do they have AML, CML? Do they have lymphoma? And these are, I think, the most important things that you should do. You should be trying to exclude malignancies and infections, which is another topic that we need to exclude. And then other entities like systemic mastocytosis and histiocytosis X or Langerhans cell histiocytosis also need to be excluded. So there you're going to see a workup, oftentimes in conjunction with a hematologist, and you're going to need to do a bone marrow to help differentiate these different entities. So when I see someone with hypereosinophilia who's got constitutional symptoms, they've got really high eosinophils, I almost always work in conjunction with a hematologist. Now, other patients, you have to take a good history, and you want to get good clues into what's going on. And we all know that asthma is associated with eosinophilia. Usually, eosinophil counts are in the 300 to 500 range, but there are some patients who have hypereosinophilic asthma with eosinophil counts in the thousands as well. And for those patients, you need to make a diagnosis of either hypereosinophilic asthma or EGPA. Other entities that can be associated with eosinophilia, more type 2 inflammatory disorders, eczema, drug reactions, allergic bronchopulmonary aspergillosis, which is associated with sensitization to aspergillus and associated with elevated IgE, and you can have precipitants to IgE as well. And then Gleick syndrome, named after Jerry Gleick, which is a pattern of cyclical eosinophilia with fevers and lymphadenopathy, amongst other things. Really critical to exclude infectious causes, because there are many infections that can be associated with eosinophilia. So when I see someone who comes from outside of the United States, I try to take a good history and see whether or not they've been exposed to some endemic parasite or helminth. Could they have strongyloides? Could they have toxicara or anything else? Other fungal infections, viral infections, mycobacterial disease, and bacteria rarely can also cause eosinophilia. Then there are the rheumatologic conditions, and in addition to EGPA, other disorders, including IgG4-related disease, Behçet's disease, sarcoid, lupus, eosinophilic esophagitis, eosinophilic pneumonia can be very difficult to distinguish from EGPA because it's also often associated with asthma, sinus disease, eosinophilia, but has pulmonary infiltrates, but no systemic manifestations. And then other chronic inflammatory diseases like inflammatory bowel disease. So critical to exclude and eliminate other causes of hypereosinophilia, whether it's a drug reaction, whether it's allergic reaction, whether it's a malignancy, an immunologic disorder, or other miscellaneous entities that can be associated with eosinophilia. There was the World Trade Center, when that came down, there were a lot of firefighters who ended up having hypereosinophilia due to some unclear toxin that was observed there. And many of those patients developed either hypereosinophilic syndrome or eosinophilic pneumonia or EGPA. So in terms of making a diagnosis of the hypereosinophilic syndrome, the patients need to meet these criteria: an eosinophil count of 1,500 on at least 2 occasions and at least 2 weeks apart. So it isn't just a single isolated eosinophil count. Or they need to have a histologically proven hypereosinophilia in their tissue, either in the bone marrow or in any other tissue, or if you see deposition of eosinophil granular proteins like eosinophil cationic protein, major basic protein, eosinophil-derived neurotoxin, or eosinophil peroxidase. And you also need to have some form of eosinophil-mediated organ dysfunction or damage without any other secondary causes. So high eosinophils, some other organ infiltration, and absence of other known causes. And the manifestations of HES really can vary across patients, but can affect any organ system. It can affect the lungs, central nervous system, the peripheral nervous system, the skin, the GI tract, the heart, and oftentimes these patients will have, in severe cases, congestive heart failure, myocarditis, Intracardiac thrombi can be really devastating and really does these patients in. On top of all these organ-specific causes, and with pulmonary, you see in addition to asthma and wheezing, you might see pulmonary infiltrates as well. They can have diffuse pulmonary infiltrates. But oftentimes there's constitutional symptoms, including night sweats, fevers, itchiness, myalgias, and all of those can result in presenting to a doctor, and then you identify the eosinophils. Sometimes patients present with eosinophilia, and sometimes they present with all these symptoms, and you identify the eosinophilia. But patients can present with any one of these organs involved or many of these organs involved. And that's what makes it very challenging, because sometimes they'll present to a pulmonologist, sometimes they'll present to a cardiologist, sometimes they'll present to a neurologist, sometimes they'll present to a hematologist, or they might come to the emergency room, or they might have a rash. And all these people need to have an awareness of these hypereosinophilic syndromes. When I see patients in whom I suspect HES, I refer them to a hematologist almost always. And what we can do is you can do immunophenotyping and flow cytometry. You can do lymphocyte phenotyping, TCR gene rearrangement, and you can also try to identify and see if there's a clonal or lymphoproliferative disorder or mastocytosis. On top of that, one does cytogenetics and FISH testing, particularly to look for the myeloproliferative variants, like the FIP1L1 PDGFR alpha fusion protein. But there are other genetic mutations that have also been associated with myeloproliferative HES as well. Another mutation is the CHIK2 deletion or a 4Q12 mutation. So you can send all those off to a central lab where they'll measure all of these things. You can do karyotyping to look for clonal HES as well. And then you can also look for somatic variants. I think it's really important to do bone marrow evaluations in these patients. It's also important to do tissue confirmation of the organ-specific tissues to see what's going on. Do they have evidence of vasculitis? Do they have evidence of infection? Oftentimes, the goal is to just exclude malignancy and infection as part of your workup. But you can also identify the specific type of eosinophils. What's the eosinophil morphology, and what are the granules that are being produced? It's been shown that high eosinophils are associated with increased morbidity and mortality, actually. And eosinophil counts are generally the best biomarker to predict and monitor disease activity. And patient-reported outcomes usually guide how we manage these patients and how we assess them. The bad prognostic factors include being older, having an age greater than 60, having a hemoglobin less than 10, having cardiac involvement, having hepatosplenomegaly, and those factors are associated with reduced outcomes or increased mortality in those patients. You can see if you've got no risk factors, you have a 98% 5-year survival, and if you have any of these risk factors, then your survival goes down to 62%.
Thank you. All right, so EGPA, again, my colleagues have talked about it, but you have inflammation of the blood vessels, and you also have this profound eosinophilia. So more than 90% of patients with EGPA have asthma. Often it will present in adulthood, although patients can have a history of childhood asthma, and then they're having more exacerbations. They're not usually seasonal specifically, and they just are kind of chronically being treated with courses of prednisone or different treatments to just try to get their asthma under control, but it can be very persistent. So there's also a lot of involvement of ENT symptoms, so a lot of nasal polyposis. One of my ENT friends said, like, if it's a cute little nasal polyp, that's not so concerning, but these are like angry-looking nasal polyps, and sometimes I will have my ENT colleagues go in and do biopsies of those, but those can be also very difficult and make it tough to breathe. And of course, that eosinophilia. Because these patients are often on courses of prednisone, so you want to look historically at their records because the prednisone can mask that eosinophilia. So make sure you're looking back into their chart to see if they have history of sort of bumps in between those prednisone courses. So it should be considered in patients with asthma, with nasal polyposis, and with eosinophilia. In terms of ANCA positive versus ANCA negative disease, there are certain classical organ manifestations depending on ANCA positivity or negativity, but I will say that any patient, whether or not they're ANCA positive or negative, can have any of these organ systems involved. but it does help sort of create some sort of framework and things you should be thinking about. So these ANCA negative patients often will have cardiac involvement, which is the biggest driver of mortality in EGPA patients, lung infiltrates, flare-ups of their asthma, pleural effusions, GI involvement, whereas the ANCA positive patients, usually MPO positive, have more mononeuritis. Renal involvement is rare overall compared to the other ANCA vasculitides, but renal involvement, mononeuritis, alveolar hemorrhage, and purpura are things that you think about with ANCA positive disease. So luckily, we did update some of the classification criteria. The ACR, American College of Rheumatology, and EULAR made classification criteria updates in 2022. The ones before that were from 1990, so it was way overdue. It's important to remember that classification criteria are really there to enroll patients in clinical trials, but we do sometimes use this in terms of guiding our diagnosis. And you can see here that the clinical criteria that give you points for EGPA include the things that we know about. So obstructive airway disease, nasal polyposis, and mononeuritis multiplex. These are common clinical features in our EGPA patients. And then the lab and biopsy criteria, the elevated eosinophil counts, a biopsy showing this vasculitis and eosinophilic infiltration. And then you actually lose points for having a PR3 antibody or c-ANCA, and you lose points for hematuria. And the reason for that is not because you can't have that in EGPA, but you're really trying to differentiate between the different small vessel vasculitides, and those are more commonly seen in things like MPA or GPA. So of course, you want to rule out mimics. We talked about how important that is with HES. It's also important with EGPA. In terms of prognosis with EGPA, this is called the 5-factor score, and we do use this sometimes to determine how aggressive to be in terms of our treatment. I will say that it was originally developed between a combination of patients who had EGPA, polyarteritis nodosa, and GPA, so it's not necessarily specific only to EGPA. But essentially, it's looking at the risk of mortality in these EGPA patients. So if you have a 5-factor score of 0, you do better, you survive more. And if you have elevated 5-factor score, you do worse. So with with a 5-factor score of 1, you kind of drop off in the beginning and you have a lower or higher death in the early years, and then you kind of match up with the 5-factor score of 0. And an elevated 5-factor score more than that is really a poor mortality indicator. The criteria that go into that are older age, heart involvement, kidney involvement, GI involvement, and then the absence of ENT manifestations. Again, this was a cohort built on more than just EGPA patients. So do you have the right needle in the right haystack? So we talked about how all these diseases can affect so many different organ systems, and we have to try to sort through what exactly is going on. So is it EGPA? Is it HES? Is it a different type of ANCA vasculitis? And you can see here there's a lot of overlapping manifestations. I talked a little bit about distinguishing between the other ANCA vasculitides and EGPA. But again, small blood vessel inflammation, you have small blood vessels all over your body. You can have different organ manifestations. We do think more about EGPA, of course, with the nasal involvement or nasal polyps and asthma. And you have a lot of cardiac manifestations, eosinophilia, which is not seen as much in the other ANCA vasculitides. And we'll get a little bit more into how to differentiate between EGPA and HES, but of course you don't have some of these mutations that are specifically there. You're really looking at the clinical presentation and then some labs findings that can help support this, and biopsies if they're available. So differentiating between EGPA and HES, I just talked about that a little bit. So similarities between these two entities are that they both can have a persistent eosinophilia, sometimes higher, right, in terms of criteria for HES, but you can definitely have EGPA with really, really high eosinophil counts. And they can both have significant systemic manifestations. Some of the differences that might point to EGPA are that you have frequent asthma and nasal polyps that are really bothersome to patients. And then, of course, vasculitic complications, the ones that I kind of mentioned. If you get a biopsy that's showing you vasculitis, that's going to fall more into EGPA, right? And then ANCA positivity is really only seen in about 40% of these patients, but it usually is MPO or PANCA positive. Again, you can have the disease with or without ANCAs. And then differences pointing towards HES include the PDGFRA fusion mutation, hematologic abnormalities. Again, you guys are usually working with your colleagues or hematology colleagues to figure this out. So a 56-year-old woman presents with asthma, a 5-year history, well-controlled, and recent abdominal pain, urticaria, and fatigue. Her blood EOS count is 3,500. What would you do next? An endoscopy, MPO ANCA testing, bone marrow biopsy, FISH PCR for the fusion protein, or all of the above. You guys have your little clickers. All right, so 50% of you, yeah, I would do all of the above here. Again, they're all gonna give you different types of information, but with that history, it would make sense to look for all of these possible options. Oh, faculty discussion. What is the best process to determine if a patient has HES versus EGPA? I think we talked a little bit about this, but if either of you wanna take a shot, we can just move on.
I mean, I think in the interest of time, we maybe move on, just because I think you did such a great job covering the difference. Okay. So Euler treatment algorithm. Again, we base our treatment of the disease on how severe the patient is, what the severity of the organ involvement is. So one of the first questions is that's not actually, I'm just gonna pull this all up so I can talk through it. Okay. So if you have a patient who has active EGPA, is it organ or life-threatening, or is it not organ or life-threatening? If it's organ or life-threatening, we're usually reaching for something like cyclophosphamide or rituximab. Both of these have been shown to be effective in EGPA. The RIOVAST trial recently looked at rituximab, and it is non-inferior to Cytoxan. We're also using, of course, glucocorticoids. If it is not organ or life-threatening, then the Euler or algorithm says, is it relapsing or refractory? And if it is relapsing or refractory, then we should use an IL-5 or IL-5R agent. ACR criteria or ACR recommendations are to use an IL-5 blockade up front. And again, we're often using corticosteroids because they can help with rapid control of these symptoms, and we're trying to taper them down, and we often don't do a great job of that because it's really difficult to get them towards low doses. Adding the IL-5 blocker can definitely help. So that's what we do with remission induction. And then we switch over to maintenance. So if you are able to get the disease controlled on either side, and you have brought down their steroids, and then the question is how long, patients are always gonna ask, how long do I have to do this for? And when can I totally come off of these steroids? So if they've achieved remission with that induction treatment that you used, then you're going to either switch to azathioprine, methotrexate, an anti-IL-5 or 5 receptor agent, or rituximab can be used, and continue to try to taper those corticosteroids. If you achieve sustained remission, then the next question is, did you achieve sustained remission? If you didn't, then they're suffering from a relapse, and then you have to go back to the beginning and reinduce them, depending again on the severity of their disease. If they did, then you're really trying to, again, chip away at the corticosteroids. We all have had patients where you go like 3 to 2 milligrams, and somehow then they flare up, and then you keep bouncing between the two. So this is when we're starting to look at adding additional agents to get them into remission. If you are able to bring it down, then you assess that patient sitting in front of you. What are their comorbidities? What are their patient preferences? And then decide about whether you want to continue or stop maintenance treatment. I will say, when I have attempted this, I usually try weaning. I don't go from 0 to 60 or 60 to 0 and just stop the medication and hope for the best, because then you're often chasing that with a lot of glucocorticoids. But you're going to have that informed conversation with your patient about really what their preferences are and how to monitor them for flares if you do try to take them off therapy. We have come a long way. It's actually very exciting in terms of our therapeutic options for EGPA over time. We were often borrowing, at least in the rheumatology world, from our other ANCA vasculitides and kind of applying that treatment algorithm to EGPA, which obviously has a distinct pathophysiology. So initially, we were really just using systemic corticosteroids. That was all we had. From the 1970s to the 2000s, you can see some of the other medication options that we were using. Again, not super well studied, other than azathioprine, which didn't even work really well in EGPA, but we were using cyclophosphamide, methotrexate, azathioprine, rituximab, mycophenolate. But really now, in the present, we have great trials that Mike has helped do that have looked at really incorporating the pathophysiology of EGPA in managing these diseases. So now we have 2 approved options, benralizumab and mepolizumab, that are targeted biologics that work in this disease, and it's really changed patient outcomes. So we all know the issues that come along with steroids. You can see this long list here, and all of us have patients that come in and just, they're ravaged by these different side effects. It's miserable from a day-to-day basis, high doses, low doses, short-term, long-term.
all of these sort of possibilities are going to create significant issues for your patients, whether that be trouble sleeping or osteoporotic fractures, and we have to be screening for some of these corticosteroid-related comorbidities in our patients and really trying to manage them aggressively, and more importantly, getting them off glucocorticoids. Here you go.
So as Anisha mentioned, we've got great options. We have 2 new therapies that have been approved for EGPA in the last 8 years or so, mepolizumab and benralizumab. Mepolizumab that targets interleukin 5 and benralizumab targets the IL-5 receptor. These are both indicated not just for asthma, but also mepolizumab is indicated for eosinophilic asthma, eosinophilic COPD, as well as chronic sinusitis with nasal polyps, and EGPA and HES as well. These therapies work by blocking IL-5, or benralizumab binds the IL-5 receptor. And by binding the IL-5 receptor, it has the dual effect of not only preventing IL-5 from binding to the receptor, but also can result in an antibody-dependent cell-mediated cytotoxic effect, because the body recognizes the benralizumab bound to the IL-5 receptor as foreign, and it'll attract natural killer cells that will come and deplete eosinophils. So with benralizumab, you see actually greater depletion of eosinophils, whereas with mepolizumab, you see a reduction of eosinophils, but not a complete depletion the way you see with benralizumab. Now, these therapies are both very effective, and it's been demonstrated to be effective in the management of EGPA. The first study was called the MIRROS trial, and this was a study that we published in 2017. And it was based on a double-blind, placebo-controlled study in patients who had relapsing or refractory EGPA. And they were administered mepolizumab, 300 milligrams a month, which is 3 shots compared to the asthma dosing of 100 milligrams a month. Patients get 3 shots a month versus placebo. They got 3 shots of placebo in this study for a year. And it was demonstrated that the proportion of patients who were able to achieve remission. Remission was defined in this trial as having a Birmingham Vasculitis Activity Score of 0 and being on 4 milligrams or less of prednisone. And you can see the proportion of patients with placebo. Only about 3% of patients treated with placebo were able to achieve remission, whereas you had over 30% of patients treated with mepolizumab were able to achieve remission. When you look at the participants who had a relapse, the proportion of patients treated with mepolizumab had half the relapse rate compared to those treated with placebo. So it was really exciting, and this led to the approval of mepolizumab in 2017 for the management of EGPA on top of its approval for eosinophilic asthma. In addition, patients started off with around 10 to 12 milligrams of prednisone, and with mepolizumab, we got down to about 5 milligrams of prednisone, whereas with placebo, there was no significant reduction. Patients stayed at around 11 milligrams a day of prednisone. When we look at a comparison between these 2 therapies, mepolizumab and benralizumab, this is the first head-to-head direct blinded biologic study looking at any of these asthma or asthma-related diseases. This is called the Mandara trial. In this study, patients who had relapsing or refractory EGPA were randomized to receive either mepolizumab, 300 milligrams once a month, or benralizumab, 30 milligrams once a month. The dosing in asthma for benralizumab is 30 milligrams once a month for 3 months, and then every other month thereafter. And what was demonstrated, again, when we looked at the proportion of patients who were able to achieve remission, there was no significant difference between these 2 strategies. So mepolizumab, which was approved in 2017, now we have benralizumab that was approved, I think, in 2024, based on the results of the Mandara trial. You can see that a large proportion of patients were able to achieve remission and have sustained remission and have no significant relapse. Here in this study, only around 35% of patients demonstrated a relapse. When we look at the 2-year efficacy, so patients who were in the Mandara trial were then allowed to continue on in a long-term extension study. And what you can see here in the green and the red is patients who were treated with mepolizumab and switched to benralizumab, or patients who were treated with benralizumab and stayed on benralizumab. And what was demonstrated was there was sustained remission on the order of around 65% of patients in their second year of treatment with an anti-IL-5 agent who were treated with benralizumab were able to have sustained remission. The other important thing that we looked at was the proportion of patients who were able to come off of oral corticosteroids. We heard from Anisha that patients hate being on oral corticosteroids. And what was demonstrated at the end of the first year of the trial was that around 44% of patients treated with benralizumab were able to come off of oral corticosteroids, compared to about 26% of patients treated with mepolizumab. You should know that in the MIRA study, in the placebo group, only 3% of patients were able to come off of steroids. So here we have, in this study, 44% of patients treated with benralizumab, 26% of patients treated with mepolizumab able to come off of steroids. And when patients were switched from mepolizumab to benralizumab, you see that there's an additive gain of, again, up to around 44%. So patients who were switched from mepolizumab to benralizumab had an additive effect, likely due to the greater depletion of eosinophils that was observed in those patients. In terms of steroid sparing and getting patients down, from the MIRA study, I already mentioned that patients started off at around 10 to 12 milligrams a day. With mepolizumab in the MIRA study, the first study that was from 2017, patients got down to around 5 milligrams a day, whereas patients in the placebo arm stayed at around 10 to 11 milligrams a day. This is really important because, again, patients hate being on oral corticosteroids. And when you look at not just the final dose achieved, but the overall average dose of corticosteroids, it was lower with mepolizumab in this trial. In the Mandara study, where we compared the two, you can see here the proportion of patients who had a 50% reduction in their oral corticosteroid dosing. In green is the benralizumab patients, and in red are the mepolizumab patients. And when you look at the proportion of patients who had a 50% reduction in oral corticosteroid dosing, with benralizumab it was around 85%, compared to mepolizumab 74%. When you look at the proportion of patients who had a 100% reduction in steroid dosing during weeks 48 to 52, 41% versus 26%. And then when you look at the proportion of patients who got down to 4 milligrams or less, it's comparable, around 69% for both these patient groups. So I think we want to try to get patients off of steroids. These therapies, both benralizumab and mepolizumab, are very effective in getting patients to lower doses of steroids and even off of steroids. And this is unheard of prior to the era of biologics. It's also important to recognize that while these therapies are depleting eosinophils, they're generally very safe and well tolerated. While many patients reported adverse events, when we looked at the MIRA trial where there was a placebo comparison, there was no significant difference in safety in terms of adverse events compared to the placebo group. And the data with benralizumab and mepolizumab show that they're comparably effective and also comparably safe. This study was done during the COVID pandemic, and so you can see that around 20 to 30% of patients developed COVID. Some other patients had headaches, as well as arthralgias, nasopharyngitis, sinusitis. Right now, I'm experiencing all those symptoms independent of being in a clinical trial. But generally, these therapies were very safe and well tolerated, with no significant adverse events leading to discontinuation of treatment. So here's another case of Brian, who's a 55-year-old man who presented with severe asthma. It was diagnosed 5 years ago. He was hospitalized for new heart failure, and he was found to have acute kidney injury with active urinary sediment. He was diagnosed with ANCA-positive EGPA. His other medications include his inhaled corticosteroids, long-acting beta agonists, long-acting anti-muscarinic agents. So here's a guy diagnosed with EGPA. He's got cardiac involvement. He's got renal involvement. Did those factors change his initial treatment options?
Yeah, I mean, this is life and organ-threatening disease, right? This guy is very sick. And so I would use either cyclophosphamide or rituximab up front. But I will say, we know that cardiac involvement has a lot of eosinophils in it as well. So again, sort of off the guidelines, I usually use a combination if I can, so I would probably consider rituximab or cyclophosphamide, and also try to get an IL-5 blocker of some sort on board if I can, to get this under control. And of course, we would be using high doses of steroids up front. So yeah.
Does his ANCA status change which of those therapies you'd give? Would
No.
you more likely to give rituximab versus cyclophosphamide?
So that was a big question, and so theoretically, everyone thought that rituximab might work better in ANCA-positive disease, just based on the mechanism with ANCA production. And historically, we've had more data for cyclophosphamide, and so when people had cardiac involvement, if you look at the ACR recommendations, they say if they have cardiac involvement, maybe lean towards cyclophosphamide. There was a more recent trial, the RIOVAST trial, that looked at rituximab versus cyclophosphamide in these really sick patients with high 5-factor scores. And in fact, they both were pretty equally effective. So I have recently been moving more towards rituximab just in terms of the safety profile in managing and inducing these patients.
Because cyclophosphamide has many more side effects, bladder malignancy and other malignancies as well.
Yep.
The reason that anti-IL-5s aren't necessarily indicated in this patient population, we didn't study. It's really hard to do clinical trials in these rare patient groups. And so we don't have an answer for whether or not an anti-IL-5 may or may not be effective for the acute management of EGPA. But it theoretically could, because what you want to try to do is deplete the eosinophils. And that's what drugs like cyclophosphamide are doing. They're just depleting the entire bone marrow. Yeah. But there have been some case reports where patients have been given anti-IL-5 therapies up front for inducing remission, getting as induction therapy. And many of those patients have done quite well, just there hasn't been a clinical trial yet to demonstrate that degree of efficacy. So here we have another question. A 71-year-old man with a 10-year history of asthma was diagnosed with ANCA-negative EGPA 2 years ago. He'd been taking methotrexate with prednisone, 7.5 milligrams a day, and then he had a flare of joint pain and more difficulty breathing for a couple of months. His prednisone dose was increased to 15 milligrams a day, and he's been unable to taper despite multiple attempts. Which of the following is the most appropriate next dose? Discontinue methotrexate, add rituximab, and taper the prednisone. Discontinue prednisone and add an anti-IL-5 therapy. Continue current medications, add an anti-IL-5 biologic. Or discontinue methotrexate, add cyclophosphamide, and taper prednisone. Let's hear what you guys think. Okay, so many of you chose continue the current medications and add an anti-IL-5, IL-5 biologic. I think that's based on the MIRA and MADARA trials. That's the correct answer. This is a patient who had relatively stable EGPA, but just couldn't get off of steroids, had a flare, but doesn't seem to have organ or life-threatening disease. So the best way to get these patients off of oral corticosteroids or to taper corticosteroids is to add on an anti-IL-5 agent. So Flavia, what is the best strategy for tapering steroids in patients with EGPA without risking a disease flare?
Yeah, I mean, I think having the ability to start a biologic before you taper is helpful, and then just being really cautious about the taper and setting realistic expectations with patients, because they might feel tired and achy, especially the first couple of days after decreasing the dose, and that's not a reason to go back up. But if the patient doesn't realize that that's not a reason, then they're going to be asking to go back up. Oh, I'm flaring, I'm feeling terrible, and really focusing on what is or is not flaring, going slowly, especially as you get to those lower doses, more the physiologic replacement, where now you might be going 1 milligram a month as you're kind of trying to get them off, and that's fine. And if you're struggling there, then I usually will get endocrine involved in terms of kind of helping me with that endpoint kind of tapering.
What about you, Anisha? What's your strategy for tapering, and how quickly do you go, and when do you involve endocrine?
I mean, I go quickly at the high doses, so I usually can get them down to 10 milligrams reasonably quickly, even with severe disease. It's at those lower doses where you really start having problems, and even with those slight changes, like 2.5 milligrams or something, patients will definitely feel. It's really important to tell them, you're going to feel kind of crummy for at least a couple days when you make those adjustments. But I will get involved, if I tell patients what the symptoms of adrenal insufficiency are, and of course, if they have anything like that, I go very slowly. I do 1 milligram a month, and I've had patients where I even go sort of alternating every other day. I mean, I like go 0.5 milligrams a month if it's really tough, just to try to minimize the steroids. So I'll go slow when it gets to that low dose.
Yeah, many of those patients experience, you mentioned adrenal insufficiency symptoms. Usually there's this significant fatigue or loginess that people have described. And people are miserable as they taper down. So I have a low threshold to bump up if needed, the steroid dosing. So let's move on and talk a little bit about evolving management recommendations for patients with PDGFR alpha negative HES. Flavia?
Yep, so kind of before we talk about treatment, let's be clear about some definitions. So in terms of a flare is not just an increase in the eosinophil count. You also have to have associated symptoms that are, that we can blame on the eosinophils essentially. And generally it requires increasing your therapy or including, steroid burst. And then remission is not just like 0 eosinophils, 0 symptoms. Really, it's kind of been defined as, depending on what you read, either a blood eosinophil count of less than 500 or less than 1,000, control of symptoms, so that's very important, and then lowest effective dose of corticosteroids. So again, it doesn't have to be 0 necessarily, but getting it down as far as you can and then maintaining there. So kind of thinking about conventional therapies that we've used for years with PDGFRA negative patients with HES. So obviously corticosteroids work very well, and we just talked about all their various side effects, and so this is a great acute therapy, but not a long-term therapy. And so the long-term therapies that we've had kind of at our disposal historically have been things like hydroxyurea, interferon alpha, and cyclosporin. So these are all second-line therapies. And they work in this idiopathic HES or lymphocytic HES, and they're often limited by either toxicity or side effect. And so we know, and particularly with interferon alpha, patients feel like they have the flu, and that's not a good feeling to have on a chronic basis. So it definitely limits therapy there. Cyclosporin, of course, can hurt the kidneys at higher doses, affect blood pressure. And so we know that although these therapies can get our patients off of steroids, they're limited. And that's where the biologics come in. And so we have mepolizumab approved for HES. Again, the criteria for inclusion in the trial was that the patients were PDGFRA negative in terms of mutation, mostly because for ethical reasons. So if those patients were found to have the mutation, then we know imatinib works very well, and so it would be unethical to enroll them into a trial and withhold the imatinib. And so looking at the efficacy of mepolizumab, this trial didn't have a fun name. It was numbered, and so, but thinking about the probability of flaring over time in this 32-week trial, you can see mepolizumab in red, a placebo in blue, and pretty early on, the probability of flaring starts differentiating itself between the two. So number of flares or withdrawals from the study, probability of flaring by the end of the study at week 32, and then annualized flare rate and eosinophil counts all went down. In addition, there was improved fatigue score. So even though fatigue is listed as one of the side effects of these medications, the fatigue that you're getting from the HES is obviously much more relevant, and that decreased with mepolizumab. So mepolizumab was approved in 2020, and benralizumab has not yet been approved, but does have orphan drug designation since 2019. And the phase 3 Natron study just recently was published in 2025. And so you can see here benralizumab reducing the risk of HES flare. So very similar graph to what we just saw with mepolizumab, placebo in blue, benralizumab in green. And this was looking through 24 weeks. And you can see that there was a proportion of patients flaring, annualized flare rate, risk of hematologic relapse, and then, of course, the rate of oral corticosteroid dosing. All of that was improved with benralizumab. And then again, eosinophil counts and fatigue were also improved. So really exciting data. And then looking at the steroid sparing effect of these therapies, we can see with mepolizumab that 26% of patients receiving mepolizumab experienced a flare. which obviously often is treated with oral corticosteroids, as opposed to 52% in placebo group. So we know that the steroid burden is decreased by a decreased number of flares. And then there was also a slight trend towards increased mepolizumab benefit in flare reduction with the increasing baseline OCS dose. So the higher that OCS burden, the better the impact of the biologic, which is not surprising. And then benralizumab, small numbers from the phase 2 study, but 4 of the 5 patients who responded to benralizumab at week 48, who initially were taking OCS at baseline, were able to reduce their dosage or eliminate OCS entirely. And then in the phase 3 trial, there was a similar rate to mepolizumab, so 25% of patients receiving benralizumab and about 48.5% of patients receiving placebo had to increase their dose due to flares. And so a decrease in flares, decreased OCS, and makes patients and physicians happy. So in terms of a treatment algorithm for HES by subtype, again, first step is looking for that mutation because that'll send us down a different path. But if the mutation is not found, then thinking about T-cell immunophenotype and looking for the clonal T-cell receptor gene rearrangement. So doing that flow cytometry, getting hematology involved. If that's there, then you're left with lymphocytic HES. If it's not there and you have end organ damage present, then you're left with idiopathic HES. The treatment is going to be similar between the two. So corticosteroids, interferon alpha, hydroxyurea, mepolizumab. You see that on both lists. For idiopathic HES, some patients can be trialed on the imatinib, so there is some data that some of these patients do benefit. And then, of course, stem cell transplant, and for both, clinical trials would be an option as well. So thinking about a case here, we have a 63-year-old female diagnosed with idiopathic HES 1 year ago. After initiating treatment with prednisone, her eosinophil count dropped from 4,600 to 400. Unfortunately, 2 months ago, she reports some confusion, weight loss, and urticaria, and now her eosinophils are up to 1,800. So not quite as high, but definitely heading in the wrong direction with symptoms to match. And her prednisone dose has increased from 10 to 15, but unfortunately, symptoms are not changing. Which of the following is the most appropriate next step for her? So number 1, increase prednisone dose to 20 milligrams per day. 2, switch the prednisone to interferon alpha. 3, add imatinib to prednisone. And 4, add a biologic to prednisone. And so all of you, it seems, would add a biologic to the prednisone. Certainly we could keep going up on that dose, but if that 5 milligram increase didn't make a difference, then another 5 probably wouldn't. And again, we talked about, interferon alpha in terms of side effects. We talked about biologics in terms of their efficacy. And so a great kind of tactic in terms of kind of getting down on that prednisone and helping these patients who may not be so prednisone responsive. Okay. And so in terms of kind of a discussion question for us, what are the best practices for improving outcomes for patients with HES who don't respond to steroids? So steroids usually work, but if in the case of this patient, if they're not quite cutting it, what would your strategy be, Mike?
Yeah, so usually what I'll do is I try to step back and see, am I missing something diagnostically? Am I missing some other comorbidity? A lot of these patients, it depends on, you have to identify, what are some of the outcomes that are not getting better. So, do they have some other comorbidity? Do they have reflux or aspiration or some other process that's going on that I can address outside of their eosinophilic disorder? And once I've excluded that and I've made sure that they're adherent to therapies and we've got a confirmed diagnosis, that's when I'll add on a biologic therapy. And if the patient isn't responding to one biologic, then I might switch them to a different biologic therapy.
Yep. Dr. Du, I don't think you treat the HES patients. Definitely taking that step back is always important at any stage when the clinical situation changes. Just make sure that you're still dealing with what you were dealing with last year or a few months ago when things were actually doing well. And And so key takeaways for today, we talked a lot about EGPA and HES. We talked about the tremendous disease burden, the diagnostic delay. So really having that high index of suspicion for these conditions so that you can identify them early and reduce that higher risk of mortality that comes with these conditions. And of course, in terms of treatment, thinking about subtypes in both conditions and then tailoring the patient's therapy to those subtypes that you identify. And then, of course, with biologic therapy, demonstrated efficacy and safety in the treatment of both conditions, and importantly, allowing us to lower the dose of corticosteroids with all of its many side effects. And so we will go back to those questions that we saw at the very beginning, and let's see how much we've learned. So post-test question 1, if you want to grab your clicker, which of the following is a therapeutic target for both EGPA and HES? So the JAKs, IL-5, IL-5R, tyrosine kinase, or interferon alpha. And so all of you got this right. IL-5 and IL-5R are definitely shared pathophysiologic pathways in both conditions. I don't have the pre-answers to compare, but also we're all much more awake at this point as well. So, here we go. So 89% up to 100%. So confounded by the awake factor, but I think we learned a lot today as well. So next question, post-test question 2. So which of the following, and this was kind of a tricky question, eosinophil levels correspond to diagnostic criteria for HES and for EGPA? So read carefully and go ahead and take a stab. Great, yep, so HES it's 1,500 and then EGPA is 1,000. And that number also increased, so from 77% up to 90% correct. And the case vignette, so 65-year-old female diagnosed with HES after presenting with weakness, night sweats, vomiting, and an eosinophil count of 3,600. She's tested negative for the fusion protein, and secondary causes have been ruled out. So now you start on corticosteroids, and she's stable, so what is the most appropriate next step? So continue therapy and monitor her levels, initiate interferon alpha and wean corticosteroids, initiate IL-5 targeting biologic and wean corticosteroids, or initiate treatment with hydroxyurea and wean corticosteroids. Great, so initiating interferon alpha or hydroxyurea would be options, but IL-5 is better tolerated, and so you see most people would have opted for the IL-5 targeting biologic as a way to wean the corticosteroids. So on to the next vignette, 59-year-old male, history of severe asthma, diagnosed with ANCA-positive EGPA 3 years ago. Well managed on azathioprine and prednisone of 10 milligrams per day, but having some side effects from the steroids. So which is the following next appropriate step for him? Increasing the azathioprine dose and tapering prednisone, discontinuing the prednisone altogether, switching azathioprine to an IL-5 or 5R targeting biologic and tapering the prednisone, or switching azathioprine to methotrexate and discontinuing prednisone. Okay, so again, I think most people would be starting an IL-5, IL-5R targeting biologic, and then tapering the prednisone. And oops, yeah. So that stayed about stable throughout the from the pre to post test questions. And then next question. So, how often will you now use a biologic therapy to help taper steroids in patients with EGPA? So about 76% of you will now be starting a biologic, and that seems to be a very big increase from when we started.
Interestingly, the number of people who manage EGPA is decreased. It's great.
Maybe we had a couple of people leave. Okay, and then how often will you now test for FIP1L1 PDGFRI fusion protein in patients with HES as compared to how often you were doing it ahead of the talk? There should be another question. Can you say FIP1L1 PDGFRA? Because that's a mouthful. But again, it looks like we have a big increase in the number of folks who will be testing for this fusion protein, again, as kind of the first step of differentiating our treatment pathway for HES patients. Okay, and so now we have some time left for questions. We have some questions that have been written down from the audience, but of course, if at any point you have a question, go ahead and raise your hand and we can, I think, get you a mic as well. I don't want to volunteer that, but
we can't see with the lights.
Yeah, it's a little bright, but
if you have a question,
if you feel loud enough, you can
shout out.
Shout it out.
So here's some questions that have been given to us. One question I got is, can it be effective to switch from one biologic to another if a patient is having flares? Yeah, I mean, there are differences in the efficacy of these biologic therapies, and we showed in the long-term extension study of the Mandara trial that there were many patients who were on mepolizumab, switched to benralizumab, were able to achieve a greater reduction in eosinophil counts, and were able to facilitate corticosteroid withdrawal to a greater extent. So again, if someone's not doing well on a biologic, it is worth switching, whether it's to a drug in the same class or perhaps to a drug in a different class, because you're targeting a variety of different things. Want to answer yours?
Sure, and so one question I have here, should anyone with asthma who has other symptoms that could be EGPA or HES be evaluated for them? And I think today we talked about kind of the differential for hypereosinophilia, and we talked about kind of having that higher index of suspicion. So definitely if somebody has that high eosinophil count that kind of puts them in the range where you're thinking about these conditions, then you need to be very broad in your differential and really evaluate for them. So not everybody with asthma, again, if that eosinophil count even off steroids has never been high enough, then you don't have to go digging for these conditions in every patient with asthma. But certainly if they're having systemic symptoms that might be kind of indicative that this is more than just asthma, then yes, I would go looking for it. So.
All right, yeah, no, I agree with that. But I think, yeah, keeping a high index of suspicion for sure. Like if you start seeing these other sort of features popping up, starting to look for other disease states is important, because they are rare diseases, but they are much more prevalent in patients who have underlying asthma. So again, I would have a low threshold or encourage a low threshold to at least look for stuff. Do decreased eosinophil levels due to corticosteroid use make EGPA or HES diagnosis harder? And how can you overcome this? Yes, it does make it harder, and that's what's tough, because a lot of these patients are on steroids for control of, again, like their asthma or other symptoms, and are being prescribed that. And so when you go and check the eosinophil levels, definitely with EGPA, it'll be normal. And so then people stopped putting it on the differential. You really have to look for other sort of clinical features and look historically in their record. Look at the ER visit when they were admitted for the asthma flare, check what their eosinophil levels were, and go back into the chart and try to figure out if they were ever bumped up. And again, a lot of times as you're weaning people off of steroids, you'll start seeing those eosinophil levels come up again. So if you have suspicion for the disease and they have normal eosinophil counts and they're on corticosteroids, of course, eventually, hopefully, they will be coming down off of those corticosteroids, and then you can try to see what happens with the eosinophil levels.
Yeah, it's critical to go back and look through the records, because if you go back and identify hypereosinophilia in some of these patients, you'll see it. Many patients are diagnosed with EGPA or HES after corticosteroid withdrawal. And what happens is it's called forme fruste of EGPA. In fact, many of the early cases from the 1990s were identified when patients began to taper steroids for what was perceived to be asthma, but was actually underlying EGPA. And as new therapies were introduced, whether it was the leukotriene modifiers, or whether it was anti-IgE, or whether it's anti-IL-4 therapy, as people came off of the oral steroids that was given for asthma, that's when they became diagnosed with EGPA. Here's another question. How do I classify and manage overlap eosinophilic esophagitis with hypereosinophilia greater than 1,500 with asthma in a 12-year-old? Currently use benralizumab, but what would you do? GI wants to start dupilumab for the eosinophilic esophagitis, but I'm nervous because of the risk of hypereosinophilia in patients with dupilumab. That's a really good question. You know, you have a patient who's got eosinophilic tissue infiltration, they've got asthma, they've got hypereosinophilia, and they're also young, they're kids. So what should you do? What's the risk of hypereosinophilia in patients with dupilumab? Well, dupilumab blocks IL-4 and IL-13 at the receptor level. And IL-4 and IL-13 are involved in eosinophil trafficking. And so when you give a drug like dupilumab, you prevent the eosinophils from going into the tissue. And so the levels in the blood can get very much higher. Some people might say, well, that's a normal expected result of giving dupilumab. It doesn't happen in every patient, but there's a small proportion of patients, under 10% of patients, particularly those who have a history of hypereosinophilia, who may develop this hypereosinophilia on dupilumab. If you can give a combination of an anti-IL-5 and an anti-IL-4 therapy, then that would be great because you're going to address the hypereosinophilia and you can derive the benefit the anti-IL-4 therapy with dupilumab has. And that's what we have done in many patients. We've given dual combination biologics. Sometimes if you feel that you need to give an anti-IL-4/13 therapy for some other indication, whether it's atopic dermatitis or eosinophilic esophagitis, neither of which responds very well to anti-IL-5 therapy, then you have to do so very cautiously and monitor for hypereosinophilia, monitor for any systemic untoward effect. And so I would do it very cautiously, but I would probably prefer to give dual biologic therapy with an anti-IL-4 and an anti-IL-5 agent. The incidence, again, of having a hypereosinophilic process, whether it's EGPA or HES in patients given dupilumab, is very low, but it does occur, so you need to be cognizant of that.
Yeah, and we know that the IL-5 therapies will work to decrease the eosinophils in the esophagus in these patients with EoE, but they won't change clinical symptoms, and so it's not surprising that the benralizumab is not, completely fixing everything in that patient. So I agree. That would be one where I would do dual therapy.
There was a small study looking at dupilumab in some refractory EGPA patients who had been treated with IL-5 blockers before, and there is, it can be effective, but a good percentage of them did develop some eosinophilia or blood eosinophilia, but they didn't necessarily have a clinical flare. So we're treating the patient. So it's important to know that you can have an increase in eosinophils and you don't necessarily have to jump on and add therapies, but you would just want to watch them really closely, see if they start developing any symptoms, and then consider maybe combination therapy or something like that.
Yeah, and another option for some of these patients might be adding on anti-TSLP therapy. There was just a case series published in Chest by Sandy Nancer and David Jackson from Guy's in London, where they demonstrated that adding on tezepelumab to patients with EGPA was an effective strategy to facilitate steroid withdrawal. And there you're targeting not just the eosinophils, but you're targeting a bit more broadly upstream TSLP and some of the downstream cytokines like IL-4 and IL-13 as well. You have another question?
I do. So is a bone marrow biopsy required for HES diagnosis? So I'm not sure that it's required, but I think it's pretty much always done in the sense that you want to be, again, looking for these mutations. You want to be ruling out, I mean, we saw the differential for hypereosinophilia includes a lot of hematologic malignancies, and so you wouldn't want to miss that as you're, just decreasing the eosinophil count or decreasing, the effect on certain tissues. So I generally will get hematology involved, and then I'll defer to them if the bone marrow biopsy needs to be done or if they want to just do kind of more flow cytometry. But I think most patients, especially in those higher eosinophil counts, do end up getting the biopsy.
Yeah, it depends, to me, how long have they had the hypereosinophilia. If it's new onset, then I'm much more likely to get it. If they've got systemic manifestations, if they have a rash, or an itchiness, that raises my index of suspicion that this could be more of a malignancy, and I'm much more likely. And also, if they've got long-standing asthma and sinus disease, then I'm a little bit less likely to get it unless they have other systemic manifestations. I think those are all the questions we got on cards.
I got
Anybody
one
else?
more.
Oh, you have
one more, yeah.
Oh, yeah.
What are the clinical differences between ANCA-negative EGPA and HES?
Oh.
So I will say that, first of all, for ANCA-negative, we talked about sort of the differences between ANCA-negative and ANCA-positive, but you can have vasculitis and blood vessel inflammation in ANCA-negative EGPA, so you still can have patients who have things like the mononeuritis, the purpura, the renal involvement and stuff like that. So don't make it a completely hard and fast rule, but between ANCA-negative EGPA and HES, I would say some of the clinical things would be the recurrent nasal polyps and the ENT manifestations that are really common in ANCA-negative EGPA. I don't know, what do you guys think in terms of differentiating features? I mean,
really tough. I find it very hard to differentiate between ANCA-negative EGPA and HES. The things I use is there asthma and sinus disease, and I feel it's more likely EGPA. And if they don't have asthma, or if they're ANCA positive, but this is ANCA negative, it's important to recognize that there is, I mean, we give these definitions, but these hypereosinophilic syndromes, there's a broad group of them, and many of them have a lot of similarities. The other thing I find difficult to differentiate is chronic eosinophilic pneumonia and EGPA, because those patients have asthma, sinus disease, pulmonary infiltrates, and eosinophilia. And so those are present in both chronic eosinophilic pneumonia and EGPA. If they've got extrapulmonary manifestations or ANCA, then I say it's EGPA, and if they don't, then I say it's chronic eosinophilic pneumonia. Any other questions from the audience? Yeah. Is there a microphone, actually? Or speak louder.
Treating a patient.
You said,
Yeah, so it sounds like the question is a patient with hypereosinophilia was started on, initially was referred to you by hematology, and they were given an anti-IL-5 with mepolizumab, and yeah. Yeah, but it went down to 3,000. Yeah. And is the patient symptomatic, by the way? Is the patient symptomatic? No. So that's a great question. What do you do with benign hypereosinophilia? And if the patient doesn't have any disease manifestations, do you treat those patients to lower the eosinophils, just to lower the eosinophils? And I've given this a lot of thought. I've had many patients who have benign hypereosinophilia, and some people get very nervous about not treating those patients. I have, in many cases, monitored those patients, even with eosinophil count of 3,000, and told them to give me a call right away if they have any abnormality or any symptom that could suggest any organ involvement. Some people get very nervous doing that, but I give out my cell phone to everyone and tell them to call me. And in those cases, I tell them to get to the emergency room or take some steroids. You have to balance the risk of having a lot of eosinophils with having and no symptoms with the treatment. So you could give that person prednisone, but then you're risking the side effects of the corticosteroids or of a cytotoxic agent. I don't know what you guys would do. So someone who's got eosinophil count of 3,000 doesn't have any symptoms. Do you care?
I care, but I'm with you. I think I would just keep a really close eye on them, but I wouldn't add any toxic medications if they're not having any symptoms.
Oh, interesting.
So it sounds like more than just the eosinophils are involved then now. Okay.
I would send them to see Flavia.
Have they had a bone marrow biopsy? Yes. Okay.
No malignancy.
Okay, yeah, that would be the only worry there. And I will say, in a patient who is symptomatic with HES, and you feel like the biologic has not, completely controlled the eosinophils and the symptoms, they may just need a higher dose. In the HES trials with mepolizumab and the extension, we had them on much higher doses initially, and so. It was initially IV, and I think it went up to as high as 750 IV. And some of these patients, we had a cohort of like 6 that we continued on compassionate use for years, and we were able to get them down. But one was on 750, the other was on 600, the other was on 400. This is IV, where 75 IV is equivalent to 100 sub-Q. And then when it was about to be approved, we tried to get everybody down to the 300 milligram sub-Q, knowing that it was about to be clinically approved, and most of them were able to get there, but not all. So we did have some patients that continued to get the higher dose, obviously with a big fight with insurance. But again, this isn't somebody who I think is having symptomatic true HES, where I'm worried about organ damage and tissue dysfunction. The biologic is working, but maybe not quite enough. Then maybe that higher dose would be what they need.
I would just step back also and make sure you're not missing an infection or some other malignancy or something else. Just make sure, stool samples, strongyloides, antibodies, the whole thing. We have one other question here. Would you worry about thrombotic events with hypereosinophilia? Anisha?
I mean, I think we worry about thrombotic events with underlying vasculitis. So in EGPA generally, there's a higher risk of thrombotic events. And we're trying to be really aggressive about treating any of those cardiovascular risk factors in our patients. With just hypereosinophilia specifically, again, like we were just discussing, I don't treat a number, but I've found in my EGPA patients that the IL-5 blockade is really effective at driving down those eosinophil counts. If someone has persistent eosinophil counts, I will look for other signs of inflammation. So are there inflammatory markers elevated? Are there any sort of clinical symptoms pointing towards like even low-grade vascular inflammation? That would make me escalate therapy or try to deal with it. But in terms of thrombotic events specifically, if I just have increased eosinophil levels, I know there's the different proteins we talked about, but I wouldn't be specifically scared.
Great. All right, well, this has been a great program. We're at the top of the hour. I want to thank you guys for getting up at this crazy early hour. And I want to thank my 2 colleagues, Flavia and Anisha. Great job, great answering questions, great questions from the audience. And hopefully we'll have the opportunity to interact. We'll stay here for a few minutes if anybody has any other questions. I want to thank our sponsors as well. And again, fill out the questionnaires to your evaluation forms in order to get some continuing education credit. So thanks a lot. Have a great rest of the meeting.
Thank you.